Okay, so I think we're good to start. Good morning, good afternoon, or good evening to everyone, wherever you are. A warm welcome to the first HDC webinar of 2023. Today, our speakers will take us through the WHO Consolidated Telemedicine Guidance. And this session will provide an overview of the key steps and considerations included in the guide, featuring reflections on implementation from its champion country, Guinea-Bissau, who's here with us today. Our session will also include experiences from eSanjeevani, from Dr. Sanjay, who's here with us, the largest documented telemedicine implementation work, which contributed to the development of the guide. We'll also have contributions toward the end from our colleague Kaloyan. And at the end of the presentations, an interactive Q&A will follow where we can take questions from the audience to our speakers. So our guest speakers today are Salim Azabi on behalf of Derek Munene. I know you had Derek on the program, but he had a last-minute mission and couldn't be here with us today, unfortunately. So Salim is a technical officer in capacity building and collaboration to accelerate SDG 3B targets, if I said it correctly, here at the World Health Organization. Tiges Tamrat, she's technical officer working on digital health within the Sexual and Reproductive Health and Research Department. Dr. Sanjay Sood, Associate Director and Project Director at eSanjeevani. And we're also very honored by the presence of our colleagues from Guinea-Bissau, who will be speaking about their experience with us today. Doutora Quinta Nsumbu, General Director at the Ministry of Health and Coordinator of the project Improving the Quality of Morbidity and Mortality Data with the implementation of the ICD in the Unified Health System. She's from the Ministry of Public Health, Guinea-Bissau, and our colleague from Country Office, Claudio Muyanga, Health Information Management and Risk Assessment Officer here also at WHO. Last but not least, as I said, another addition to our initial speakers list will be our colleague Kaloyan Kamenov, Technical Officer working in sensory functions, disability and rehabilitation here at WHO. So before we start, please note that this webinar is being recorded and that we would like to make this recording available via our HDC website for the benefit of the ones who couldn't join us today. So if you have any point you'd like to make about this, please let us know in the chat. And now I'll give the floor to Salim, who will introduce today's topic and kindly agree to facilitate the session on behalf of Derek. So Salim, thank you so much, and over to you. I wish everybody a good session.
Thank you, Carolina. Welcome everybody, and welcome to this session today. And I'm happy that we like hosting this session because with the storytelling that comes from the guidance to the execution, and bringing as well people from different levels, not only one level from WHO. Just to want to mention here is like a topic, with no doubt, is like a very important topic, telehealth, and moreover with what happened with the pandemic. And I think there is no, it's obvious that like it's a word that is like coming out like a lot for the future, for what happened before, and for the future as well setting. And making sure that like we can execute like a proper like health giving in the future. It's something that can like facilitate a lot the execution within like health workers and for the patients. So yeah, definitely important. I want just to mention here the umbrella of execution and the endorsement of the the Global Strategy on Digital Health 220-225 that actually bring in this discussion here as well. That is like relying on the four pillars, or what we call objectives in our side, that was released in 2020, and then that is ongoing right now between 2020 and 2025. So the main objectives, and that relate a lot to the topic today, which are like the global collaboration, advanced transfer of knowledge, like one of the pillars. Second pillar, which is like the advance the implementation of national digital health strategies. The third pillar, which is the strengthening governance for digital health at global and regional and national levels. And the last one, but not least, which relates a lot to the topic today, is to advocate for people-centered health systems that are enabled by digital health. So I believe like, it's very people-centered like approach telehealth is bringing in, because bringing like, what we could do with people directly in executing and then facilitating their like, needs in a way that is like not like a classic mode of execution when bringing health or health services to patients. So yeah, from my side, mainly like I want to mention that like all the product that we are showing today are going to be under the umbrella of a package tool of guidance for telemedicine implementation that DHI is in charge of, Digital Health and Innovation department I work with. And we have like a working group that Kaloyan, Tigest, and many others are involved, and we're trying to bring this like package tools together to kind of like enable an environment where the execution is better, more efficient, more effective, and like to strengthen their the execution at the regional level and the country level. So yeah, that's from my side, and I will like give the floor now to Tigest, so she can go through more the technical part and have a brief overview of the Consolidated Telemedicine Guidance that was like released last year. Tigest.
Thank you, Salim, and thank you all for coming to this presentation. So as Salim mentioned, we know that there was an increase in the adoption of telemedicine globally, spurred by the pandemic. And one of the things that we recognize as WHO is that there needed to be some type of guidance that both consolidated what we already knew, as telemedicine has been a widely used practice since, the last 4 decades, but there's been a lot of new lessons and learnings that have also emerged through the implementations during the pandemic. And so we're very grateful that we have colleagues and partners from the Ministry of Health that are able to also share some of these lessons from there. So the Consolidated Telemedicine Guidance, I will just take a moment to share my screen. Please let me know once it's up. It grew out of this recognition, and where I sit specifically within a programmatic unit at WHO.
It's not coming yet. Okay, now you have it.
Okay. Is it in full display mode?
No, not in full display. No, not yet. If you can just do that.
Okay. Okay, let me just try. Okay. Let me take another attempt to share my screen. Are you able to see it?
Yes, you do, guys. I think you can proceed. Just if you can put in the slide mode presentation, will be perfect. Over to you. But you still follow the line, guys. I think you have some.
So maybe just to want to add is that this Consolidated Telemedicine Guidance, it seeks to try to bring in the knowledge that had been generated prior to
Guys, I'm excuse me to interrupt you. I think we have some issues on your connectivities and your sharing screens. If you can hear us, would you mind just to reconnect again and try to probably share your slides with you, Salim or Carolina, and then we present it to you. Over.
Yeah, maybe I can just like while we waiting for tickets to come in, mainly like just to talk a little bit about the guide and the what is it in it, what we will find in it is like mainly like the guide like is like mainly kind of a tool that give you like kind of a comprehensive overview of like key planning, implementation and maintenance processes to inform like kind of a costed investments plan. And the idea is to execute like through stages that like Tigest is gonna go through once she's in. It's pretty like comprehensive. I believe like Dr. Sanjay Sood as well. You'll be able to kind of like as well afterwards give us more of your input as like kind of one of the largest documented telemedicine implementation into like how the guide can be used, or how your input was to the guide from your execution. Maybe while waiting for your guest to be here, till she connects, maybe you can give us some insights, and then we can go to her afterwards with more technicalities.
Salim, before Professor Sanjay should take the floor, I just want to emphasize what you mentioned to us regarding the telemedicine, WHO telemedicine implementation guide. So WHO consists in the process to launch and publish technical products. These technical products, they are reflected in recommendations in instructions how WHO emphasize the process to implement telemedicine, which is this case. So this guide is a reference of recommendations based on contents from country experience, from other guidance from WHO focused on telemedicine, in order to support countries in the process of implementation of telemedicine at the national level. So this is as a recommendation which serves as a reference for countries in order to promote and also to promote telemedicine among national levels and subnational levels. We have a very good experience from Professor Dr. Sanjay Sood, and also Guinea-Bissau, our colleagues from the Ministry of Health and Country Office, which will support ourselves how this guide is being implemented so far. Thank you so much for introductions. Then I'll pass the floor for Professor Sanjay Sood, just to give us and share some experience based on what Salim already introduced. Over to you, Professor Dr. Sanjay.
Thank you very much, Bento. And thanks for giving us this opportunity to talk about the experiences we've learned while implementing the telemedicine program here in India, which is eSanjeevani and is shaped into the National Telemedicine Service of Government of India. The guide, as Bento also mentioned, it does give a very clear insights into the way telemedicine systems are to be conceptualized, how the situations around at the ground are to be assessed before the implementation starts. And then the guide also gives a very good idea about how the implementation is to be carried out. It explains various aspects for both scenarios. Number one, where the telemedicine program is to be implemented independently without any connectivities or integration with electronic medical records which are existing in the field or in the region. And then it also talks about how can we integrate telemedicine platforms which are to be set up in the regions where there are electronic medical records already implemented. I guess Tigest is already there. I'll hand over the control to Tigest.
Thank you. And I've actually shared my presentations with other members of the team. If maybe Pascal or Carolina, if you're able to share it for me so that we avoid any issues. I apologize. It always happens on these digital health calls that there's always these issues. And I think there's been sufficient background shared by other presenters. So I'll go straight into it. But essentially, the Consolidated Telemedicine Guidance takes into account previous resources that have been generated from WHO across the different regions, as well as the newfound learnings that were emerging during the last 2 to 3 years. And it's broken down across 3 different key stages in a way to try to both simplify the ways that we can view telemedicine. I think oftentimes this is an area that requires both programmatic as well as digital health focal points to be able to work together on. It can look a little bit overwhelming. So in a way, this guide is trying to provide a stepwise approach to systematically go through the process. Next slide, please. And one of the things that we identified when first developing this guidance document is that there was a lot of ambiguity potentially across different terms of telemedicine versus telehealth, virtual health. So in a way, this guide was trying to disambiguate and provide some clarity across these different terms. As we all know, digital health is a very evolving field and terms change quite often, but in a way, we went to recognized sources, including WHO and other areas, to understanding, what is the definition of telemedicine, which is the delivery of healthcare services where distance is a critical factor. We understood that telehealth to be even a broader definition than telemedicine, and it could include other applications of technologies for health, including distance education, which isn't directly in the context of service delivery. And this also noting that there's virtual health and care. There was a Broadband Commission report that came out early last year that was also talking about this area. And there's a lot of overlaps, but for the purposes of this guide, we try to clearly put out some definitions, knowing that this can change over time. Next slide, please. And just recognizing also that there's different ways that telemedicine can be provided. I think back when this started in the 70s, the technologies were not as diverse, there was a store and forward modality, which is the process of sending information remotely, in which a health data is shared for analysis by oftentimes a specialist health worker in another area. It was done as asynchronous, meaning that it was not done in real time, and someone else, for example, an ophthalmologist, could review the data and send back diagnoses. We know that now this can be done a lot faster, and that there's also other technologies such as chatbots that are coming in the way that could, provide this, as well as with the emergence of machine learning and AI to be able to do some visual scanning. So just these are the buckets of traditional telemedicine, but noting that this will largely continue to change with the emergence of new types of technologies. Then there's the interactive consultations, which are the ones that we're oftentimes familiar with, which is the ones where you're actually having a real-time synchronous, or what's called like teleconsultations between, it could either be a patient, a client, and a health worker, or it could be between two different types of health workers. So maybe a community health worker, or one that's a little bit less skilled, with one that's in a remote location, oftentimes providing more specialty care. And then there's remote patient monitoring, telemonitoring, where this includes the monitoring of specific parameters. And now increasingly we see sensors and connected medical devices and wireless devices that can also be part of this. So this is just a nutshell. Part of what the guide tries to do is to try to delineate a lot of these different types of approaches. Next slide, please. Next slide. These are just some use cases. So just to say that it's bringing together all these, and it's really framed after the Digital Implementation Investment Guide, which was released back in 2020, which is how do you implement digital health in a systematic way that also leverages a broader architecture, standards, as well as its costing and monitoring and evaluation. So taking into account all of these existing resources, which aren't necessarily linked to telemedicine. Next slide. And we also recognize that at WHO, we have very specific telemedicine guidance, either for assessing the maturity level, assessing accessibility, which Kellyanne will speak into, M&E, ones that are just very specific to a region or specific to COVID-19. So how do we bring all these together into one comprehensive guidance, and one that could be used not just in the context of COVID, but even sustaining implementations beyond? Next slide, please. So the guide is split into 3 phases. The first is a situational assessment. So this, and I'll go a little bit into these, but this includes the groundwork that's needed to forming the team, understanding the health program context, how is it going to run, what types of applications you intend to use, and very importantly, the enabling environment. And then we go into actually planning that implementation. And it's structured in a way with checklists, with key points to consider, so that it could hopefully be operational and be almost like a guidance tool to really make sure that all the key considerations and best practices are taken into account. So things such as mechanisms for patient and health worker safety, the standard operating procedures, patient engagement, how do you make sure that you have the appropriate community mobilization, and ultimately developing a budget that reflects all of these considerations. And then lastly, the monitoring and evaluation and continuous improvements, as well as risk management. Next slide, please. So I'll just skip over this, but just to say that one of the key things also is that within our department, telemedicine has been a very key component for abortion services, for family planning, for self-care, and a lot of these tools require potentially extra sensitivity as well in the design of the telemedicine programs. Next slide, please. So just coming back to the phase one, forming the team. So this is understanding the different stakeholders, the health program context. So is this going to be at the primary healthcare level? Is this going to be for tertiary care? Are there different digital applications? I heard Dr. Sanjay at the beginning mention how will this link to potentially EMRs that might be available, or even laboratory services, prescription services, and then considerations for the enabling environment. Next slide, please. And I'll just go through these really quickly. We can flip through these. So just borrowing from the Digital Implementation Investment Guide, knowing that you need actors that represent the regulatory and governance. So this could be the policymakers, telecommunications regulatory bodies, those that are also necessary for the health financing and reimbursement and payment of services. And this is particularly important for telemedicine because one of the big issues that comes up is who pays and how will they pay with this new mode of delivery. And it'll be really great to hear from the speakers about, how is this being addressed in terms of when you switch to this virtual mode, how does that financial transaction for payment of services come up? And that's a common question that we get. And it's something that requires, even at the outset, making sure that you have the health financing bodies available during the design and the implementation, as well as the management. So this is the actual administrators, the digital health national coordinators, the health program leads, the clinical service leads, so that they can be there to design and provide the clinical expertise, and then the operations. So the coders, those that are developing the app, the trainers, both for the health workers as well as the end users. You may also need a help desk support system. And then ultimately, very importantly, the end user representatives. So this could be patient groups, family groups, this could be professional bodies, representing the nurses or the physicians or the particular health worker cadres that will be involved. Next slide, please. And then understanding, okay, what are their existing workflows? Knowing that a lot of this may change, or as much as possible to minimize the disruption to these changes, or understanding what additional efforts would be needed to help adapt to the changes that the telemedicine implementation will provide. So we provide some examples of documenting workflows. Who are the targeted end users? At what level of the facility will this be done? Will you include different geographic areas? And key consideration for telemedicine is, will this cover different jurisdictions? So is this going to be something that's going to be across 2 different districts of one country, 2 different countries, and was it a regional system? So this is, these are all really key questions, and there's additional considerations around these that are more detailed in the guideline. Next slide, please. And then creating that landscape analysis. So, you can use resources such as a digital health atlas to be able to map, where are other implementations that you would need to link to. And something that we don't think about as often is also the hardware needs, because there's needs for audio visual. Is this going to be something that works, offline? Is this going to be something that you're going to have to procure additional devices? Is this going to include connected medical devices? And if so, how is that going to be procured? Will there be insurance schemes that allow the procurement of connected medical devices, for example, for telemonitoring? Next slide, please. And then ultimately, the assessing the enabling environment. And there's a very great resource from PAHO on this that we've taken directly. And I won't go into too much detail in the interest of time. Next slide, please. Next slide. So this is just these are some of the examples of what's actually in the tool, and it's intended to be user-friendly in terms of assessing what's the level of maturity and types of assistance that would be needed to adapt for gaps in the levels of maturity. Next slide, please. I can keep clicking through. He can keep clicking through. So these are some of the key questions to be thinking about. So now when we get into actually planning the implementation, this is, understanding functional requirements, the mechanisms, the data, a lot of the key issues that we grapple with. And we don't have perfect answers for all of these. So we've just been talking to a lot of the experts and national implementers to see what their experiences were and derive best practices from there. So next slide, please. So these are some of the questions. Will it be synchronous, meaning will it be in real time? Will it work offline? Will it have to exchange data with other systems? Will you be using sensors? Will it be via SMS, audio, IVR, images? I mean, I think we have a lot of choices now, and we need to make sure that they're fit for purpose. Next slide, please. And I'll try to wrap up in the next 5 minutes. And then understanding what is the workflow going to look like? So earlier we tried to map what those existing workflows are. And then with the introduction of telemedicine, what does that look like? So what are there some things that will no longer be necessary? Are there some new additions that obviously will need to be accounted for, and the training and additional support that is then needed to accompany that? Is if there's a linkage to an EMR, as we discussed earlier, what would that look like? And what standards would be needed to facilitate that? Next slide, please. The data privacy. So this is a really interesting piece because you also need not just data privacy and security for the data itself, but you also need a secure location for conducting the telemedicine intervention so that it's also not susceptible to being overheard, and retaining the same type of quality of care and standard of care that you would do for the brick and mortar type of services. And other considerations also include whether there's going to be audio recording. So if you're actually going to be recording the different consultations, so not just the clinical transactions, but actually the documentation of those clinical transactions are also data that need to be considered, that also need to be protected. Next slide, please. So verification of health workers, this is something common, and I think we'll hear a little bit more about it, but making sure that there's licensing and regulation, that people can trust the service. That's a big theme that we heard a lot about, that who that you're talking to is a real health worker. Oftentimes in the virtual sense, you don't really know who the person that you're speaking to, what their credentials are. So making sure that this is enforced. And we have really good examples actually from the eSanjeevani program in terms of making sure that the verification of health workers is done, that their license numbers are disclosed, making sure that you disclose if audio recording will be done. I think this is something that we're all very familiar with when we call customer services. They say that it'll be recorded for quality assurance, but you do need to let patients know that this is being recorded, because oftentimes when they go for health services in non-telemedicine physical settings, it's not recorded, but in these situations it is. And so that's also, as mentioned, the liability for making sure that there are no data breaches. Next slide, please. Training and support packages, not just to the people conducting the telemedicine services, but also those that need to access it. So this, telemedicine, as we said, is very person-centered, and you need to make sure that the people that are accessing those services are equally able to engage. Next slide, please. Just quick. And we'll hear a little bit more, but the community mobilization, making sure that those outreach is done, making sure that, whether it's through pamphlets, social media, that people do know these services are there, that they can trust it. There's, potential for people to think that this may not be a legitimate service if that type of appropriate mobilization is not done, making sure that the implications for gender equity and rights is considered. So making sure that there's multiple communication channels, and maybe we'll hear a little bit about how that's been addressed. And then I'll let Kellyanne speak a little bit more to this during his session, but ensuring accessibility for persons with disability as well, and making sure that we really don't leave people behind. Next slide. So I'll just run through this. You can go to the next slide as well. But just making sure that the budgeting then is reflective of all the different phases, and not just the setup, but also the development, the deployment, ensuring if there's going to be costing needed for the integration and interoperability, putting in somewhat of what those types of cost structures would look like for scale up. So the additional trainings, the periodic review meetings, and then the sustained operations. Next slide, please. And then Lastly, making sure that it doesn't just end there, but that there's continuous monitoring and evaluation. Next slide, please. So we've covered this using the REACH framework. So this is making sure that you account for coverage, next slide, that you're accounting for effectiveness. So the REACH stands for, okay, so it starts for effectiveness, adoption, sorry, it's the RE-AIM framework, and it includes adoption, the maintenance, and the sustainability and implementation of it. Next slide, please. So including those factors. So what's adoption that you need to be monitoring by geographic area? Next slide. The implementation of it. So is it stable? Is it usable? These are the different parameters that we've put out there based on synthesis of the literature. Next slide, please. And then the maintenance of it. And then mitigating the potential risks. So knowing that there's always going to be issues, but knowing what these potential risks may be and some mitigation strategies. Next slide. So this is, in a nutshell, the summary, trying to really distill these key approaches and looking forward to hearing more from partners on their use of it. It was just launched about 2 months ago, so we're still in the very early stages, but I'm delighted to also see that there'll be counterparts from Guinea-Bissau that'll be speaking about their experience on this. Thank you, and over back to you, Salim.
Thank you, Tigist, and I hope thank you for the deep dive, because actually that was very important to set the scene and then understand more how what's the guide is about and what are the items that are important within the guide. And please go to the link that was provided by Tigist to have more insights and to deep dive to have a better deep dive by going through it, which is very interesting. One, just to relate a little bit to the data aspect, because with the health data collaborative, some aspect that were mentioned by Tigist, the fact that it's asynchronous, synchronous. So there is a lot of data exchange happening here when we're talking about telemedicine, as well, like a lot of data knowledge and information knowledge when we want talking about assessments going to the DHA and others. So that's very important. And Tigist just put the link there. So yeah, just coming back to our agenda and then going through the storytelling of our execution here. Coming back to you, Sanjay, you already had a little bit of a discussion earlier, but would love to know more about your experience. I know that you contributed a lot to the guide. You are as well trying to implement, and at the same time, we're kind of a person or an entity that was involved into the making. So I give you the floor here, and would love to know more. Let us know more now that we have more of a understanding of what the guide is.
Thank you, Azabi. I'll share my screen and initiate the presentation. I hope it is visible. Yeah. So eSanjeevani, as we talked about, is shaped into or evolved into world's largest documented telemedicine implementation in primary healthcare, and it has already served over 94 million patients remotely. And the platform is being, in a way, has been conceptualized by the Ministry of Health and Family Welfare, Government of India, and it has been implemented by Center for Development of Advanced Computing in the northern part of the country. As far as the eSanjeevani network is concerned, there are over 230 providers onboarded, and this group includes the doctors as well as the community health workers and medical specialists as well. And as I've already said, more than 94 million patients have been served. And in one day, eSanjeevani has peaked to serve over 510,000 patients remotely. And these patients were served by the doctors in over 15,000 hubs, because it has been predominantly modeled on a spoke and a hub architecture. And these hubs have the doctors seated there, and there are 15,000 plus hubs in the country. Those are serving the requests from the field, majorly from the rural parts of the country. And over 113,000 health and wellness centers, or so to say, the primary health centers have been connected with, have been onboarded on eSanjeevani, and they are connected with the hubs. And these centers are supported or serviced by the doctors in the hubs. And besides this, there's another variant, which is the provider to patient or doctor to patient variant, which is called eSanjeevani OPD. It hosts over 1,000 online OPDs, which are serviced again by the doctors, and patients, general citizens can access health services through this online OPD directly by downloading the mobile application and logging on to eSanjeevani and selecting the appropriate OPD and getting connected with the doctor or a medical specialist there. As far as adoption of eSanjeevani is concerned, it certainly has been a phenomenal growth that has been shown by eSanjeevani. It started way back in November 19, a couple of months before pandemic struck the Indian shores. The government of India had already conceptualized eSanjeevani, the National Telemedicine Service, in 2018, and we started the implementation in November 2019 after going through all the trials and tests to roll it out in the country. As far as the provider-to-provider variant is concerned, there are close to around 200,000 providers onboarded on this, trained and onboarded on it. And through this variant, over 84 million patients have been served. And this variant predominantly works in the rural areas and serves the isolated communities, etc. So the provider-to-provider variant works in a mode where assisted telemedicine consultations are provided to the patients. The patients come to the nearest primary health center, which are called health and wellness centers in our country. And the patients, in case they need intervention by a doctor, then the community health officer who's manning the health and wellness center creates the patient case, logs into eSanjeevani, and connects with the doctor at the hub, with the relevant doctor, appropriate doctor, or a specialist at the hub. As far as the other variant, which is a provider-to-patient variant, is concerned, it has over 30,000 doctors who are practicing telemedicine on eSanjeevani OPD, and it has served almost around 10 million patients. If we look at the distribution, the gender distribution of the beneficiaries on the National Telemedicine Service, it is pleasant to note that over 57% of the patients who've received healthcare or health services remotely are women, and 42% are men. And as is logical, the age group which falls between 21 to 60 are the major beneficiaries or users of eSanjeevani. So 74% of the patients who have used eSanjeevani are from the age bracket of 21 years and 21 to 60 years. And if we look at the growth, we started off eSanjeevani by doing around 100 teleconsultations every day in the month of November. So that made it to around 3,000 consultations in a month. And very rapidly, considering the potential or the benefits that eSanjeevani could provide to the users on both the sides, the patients as well as the doctors, it ramped up to the current level where we are serving around 300,000 patients every day, and on an average, each month is able to produce or provide service to around 10 million patients. And as far as the two variants are concerned, on the left we have eSanjeevani OPD, which is a provider-to-patient model. This has been modeled in a way that it mimics the hospital-based OPDs. It is a very simple process that has been designed in this particular platform, which is accessed by citizens directly to connect with the doctors. And we have a 4-step model here. The patient logs in, registers himself or herself, and then uploads the health record, selects the OPD, and then a token is issued through the SMS or the notification in the mobile phone. And as and when the patient wants to consult within that day, uses that token, logs into the system, gets into the waiting room, and is a part of the queue which is formed there by the patients who are waiting for their turn to see the doctor remotely. So as the patient moves through the queue to number one, he or she gets a call on the mobile or laptop, whichever platform or device she's using, gets connected to the doctor, and the doctor speaks with the patient, learns about the details, those have been provided by the patient, and writes an e-prescription. And at the end of the consultation, e-prescription is flashed on the screen, and a link is also SMS'd to the patient for them to download and get the medications, etc. On the other side, the eSanjeevani Health and Wellness Centers, which is a provider-to-provider telemedicine platform, has been implemented at over 113,000 health and wellness centers across the country. At the lowest tier in the villages, we have sub-centers or even primary health centers as well, which are called health and wellness centers in the country. The patient walks up to these sub-centers or PHCs, and the community health officer there at sub-centers or primary health centers learns about the medical condition, and in case the condition warrants a consultation with a doctor on eSanjeevani, the community health officer creates a patient record and connects the patient with the doctor in the hub. So that is how, again, at the end of this consultation as well, e-prescription is generated, and the community health officer, based on the medicines prescribed in the e-prescription, dispenses the medicines. So eSanjeevani is enabling equitable access to healthcare across the country, especially the rural areas or the remote limited settings. And as a result of which, we rolled it out as a minimal viable product initially, but as we started serving various health and wellness centers and various states, or so to say provinces. In India, health is a state subject, so the provinces or the states, they manage the healthcare delivery system around them as per the requirements of the populace there. So they came up with a number of innovative applications of eSanjeevani, wherein gradually we kept on increasing the scope and the functionalities in eSanjeevani. We rolled out a number of OPDs which were aiding the country's healthcare delivery system, especially during the COVID waves. And numerous lives have been saved on eSanjeevani because the doctors have been able to identify life-threatening cases like stroke and gangrene, etc., while treating the patients remotely. And there are numerous OPDs which are serving people living with HIV/AIDS. And not only that, in certain states, the states have gone ahead and opened eSanjeevani systems or made eSanjeevani accessible to the inmates in prisons, old age homes, and orphanages as well. So eSanjeevani has had a huge impact socially. It is increasing the access to specialized care even in the remote resource-limited settings, and it is ensuring continuum of care and has already started impacting the health indicators directly or indirectly. It is also aiding the economy, so to say, and I'll show in the next slide that how is it impacting the economy as well. And it has, in a big way, started bridging the digital divide which exists in the rural and urban areas in the country, and it has given an immense push to the digital health ecosystem in the country. As far as the quantified aspect of an impact is concerned, an independent agency carried out analysis or impact assessment for eSanjeevani, especially the model that works in the rural areas. They ascertained or they endorsed that it enables easy access and is certainly contactless and is free of cost service to every citizen in the country. So each teleconsultation that happens in health and wellness centers that is the provider to provider telemedicine platform, it saves a journey of around 21 kilometers for the rural patient living in the rural areas, and it also leads to the saving of up to 941 rupees, which is an equivalent of over $11 directly or indirectly. And if we look at the cumulative costs based on the number of consultations, those have already happened in eSanjeevani HWC. These are more than $797 million nationally. And as far as the objectives of eSanjeevani were concerned, these were primarily to address the shortage of the doctors at the ground level and to reduce the burden on secondary and tertiary level facilities where the rural populace would travel to the nearest bigger facilities, and those used to get crowded, as a result of which they were burdened. And then it was also meant to encourage the creation of electronic health records at the primary as well as secondary level to ensure continuum of care. And the guiding principles when we were directed by the Ministry of Health and Family Welfare were as follows: that the system must mimic the real world processes which the patients or the citizens are used to, and the interface must be very simple and intuitive. The system must be secure and scalable, and the services, end-to-end services, starting from design, development, deployment, operationalization, capacity building, must be done by the same team or one team, so to say, so that it makes it more efficient for just about the challenges to be addressed. And the key challenges those we faced while rolling out the application were that since the system was meant to be a population scale system, and India with a population of over 1.4 billion citizens, it was not an easy task for us to estimate that what kind of system would sort of be sufficient in terms of infra sizing, etc. So the data centers we felt were not really suitable for putting in place an on-demand scaling kind of a telemedicine application. Hence, we went in for hyperscale cloud systems. And then as this was a system which was supposed to scale for a considerable amount of time, so the standard operating principles or procedures, they had to be worked out on the fly as the system would evolve. So we were all the time working in very close I would say consultation with the Ministry of Health and Family Welfare, as well as the states who were defining the functionalities those they would want in the system. And there were unending rounds of capacity building because all the users, whosoever, be it the community health officers or the doctors or medical specialists, they were using telemedicine for the first time. So we were continuously running the capacity building or training rounds, which were virtually done. So all the users, more than 230,000 users, they've been trained by us remotely in number of iterations. And since the demand could not be foreseen or anticipated, the system had to be immensely scalable. And we had to have the architecture which could ensure that the system was, out and out scalable system. And this graph, which plots the utilization of the infrastructure in terms of the number of hits that the system was getting from the users. If we see on the y-axis, those are the hits in millions. On an average day, we were doing 10 million hits. So the system was scaled up to that. And suddenly we would get a spike which would push it to 3 times the actual settings or configuration of the system. So these kind of unforeseen demands or unanticipated usage of the system was something which was a huge challenge to start with, but we gradually modified the architecture to ensure that such spikes in the demand would not push the system down. So if we look at this part, before this spike, the utilization was low, and suddenly after the spike, the utilization picked up. So it is the new users got on board, and it just ambient level of the utilization increased significantly from around 10 million, I would say, hits at the server. They grew to more than 15 million in a matter of couple of days. So, and this is the current, this was the status in April 2022, and this is the status last month, that is 1st of December till 15th of December 2022. So the scaling, as we see in the previous graph, it was 15 million was the peak average, and here it has crossed 30 million hits on the server. So that is how the system is scaling, and it is a system which this was the most challenging aspect of running a platform successfully and providing telehealth services to just about every citizen who wanted to utilize the platform. And this is an interesting analysis done by the Government of India, Ministry of Finance, on eSanjeevani consultations. On the left, we have number of eSanjeevani OPD consultations. There's ones which are done by public directly. It is a provider to patient interface platform. On this end, we have a number of consultations by the million population of that particular state. And these are the states. And on the x-axis, we have the internet penetration. It clearly shows that although internet penetration for these states called UP and Uttarakhand is a lot lower, but the utilization is higher. It clearly indicates that the need for telemedicine really precedes, or rather pushes the internet penetration, even though the penetration is lesser, but the need for having telemedicine services was higher. Hence, we see that a number of states which have lower internet penetration are high on utilization of telemedicine platform. So that reflected that internet is very important for telemedicine services, not only to ensure a larger uptake, but also to ensure that more and more population gets covered by the telemedicine services. And towards the end of the presentation, I would like to include that the Government of India is ramping up eSanjeevani further, or rather augmenting eSanjeevani, and we are in the terminal stages of rolling out the second generation eSanjeevani, which is could be a month from now. And we've revamped or overall the entire architecture, made it even more scalable. So the capacities of eSanjeevani now will be more than 1 million teleconsultations every day. And it again is based on hub and a spoke model. And the best part would be that it will provide unified interface for users. That is, the doctors will not have to switch between the two applications. It will be one consolidated application or unified application, and it will support around 11 regional languages in the country, and will have lots of other functionalities wherein the users will be able to configure the platform as per their need while they use. And there are numerous innovations. Those have been induced in eSanjeevani 2.0. We have AI-based symptom checker, which will aid the doctor and improve or increase the productivity of the doctor by suggesting to the doctor certain diagnosis based on these symptoms. Those have been fed by the patients. And then real-time sharing of health records is also possible, and it is being integrated with number of point-of-care devices, which are of great use in resource-limited settings. Almost the entire medical device industry in the country has expressed interest in getting integrated with eSanjeevani, and that is how we are working on it. And around half a dozen POC devices have already been integrated. They are in the trials. And it also enables follow-up consultations, which was a huge demand from all the users, patients, as well as community health workers and doctors as well. And we've introduced a very innovative concept here just to ensure that the data that we get on eSanjeevani is complete and the doctors are able to make a good diagnosis, precisely correct or rather accurate diagnosis based on the information that comes from the patient end. We have assigned a completion score for every EHR that sends to the patient, that gets sent to the doctor. And the states could define a limit that every patient EHR or every EHR must have a score of at least 70 while it is being sent to the doctor. So interventions like these are getting into eSanjeevani to make it, to empower users as the doctors and the patients together. And it also centered around EHR guidelines and telemedicine practice guidelines of the Ministry of Health and Family Welfare. It supports the country's Ayushman Bharat Digital Mission, which is shaping into the backbone of the digital health ecosystem in the country, and an international standard called SNOMED CT, which takes care of the nomenclature, and the generic drugs, etc., are already there. And it majorly complies with guidelines for Indian government websites. And we are in discussion with WHO and ITU team. Kamanov is here, an active member who's been instrumental in putting together the accessibility guidelines for telehealth services. We are looking forward to have those also implemented on eSanjeevani. And eSanjeevani has been recognized in various platforms and has also been awarded as the best innovation in pandemic as Digital India Awards in 2020. And that is that is all we had about eSanjeevani here. I'll be very happy to address the questions at the end of the session in case you would have any. Thank you very much.
Thank you so much. Thank you so much, Dr. Sanjay. And thank you for the overview and the lot of information coming from you in implementing a big scale implementation of telemedicine or telehealth solutions. It's very interesting. One just to mention that going from the guidance is like a two-way. The guidance that the Tigger's just shown is a two-way product, in a way that implementation is like yours, bringing into the guidance information that will be used by others. And in this case, because different environments demand different ways of execution. A guidance here is kind of like an umbrella, but the execution is up to to adapt to the environment that you are in. But even in the guidance, it's mentioned that how you should make sure to kind of tweak and make sure to get the guidance adapted to your environment, and read what your environment is of need and go towards that. So that's very interesting. So we will jump now to our Guinea-Bissau team. With it's going to be in Portuguese, so there's going to be a bit of translation as much as we can. I will share the screen, Pascual, and then over to you. I'll let you introduce your speakers, and let's go to your execution. Thank you.
Thank you very much, Salim. Once again, good morning, good evening, good afternoon to all colleagues. I will ask kindly Carolina to introduce our speakers from Guinea-Bissau, Dr. Quinta Isumo, and our colleague, Dr. Claudio Munhenga. Carolina, please, the floor is yours, and then Salim, I ask you to start to present the slides.
Sure.
Over to you, Carolina.
All right, thank you, Pascual. So to present once again our speakers, our colleagues from Guinea-Bissau who are honoring us today with their presence. We have Dr. Quinta Isumo. She's the General Director at the Ministry of Health and coordinator of the project Improving the Quality of Morbidity and Mortality Data with the implementation of the ICD in the Unified Health System. So an authority from the Minister of Public Health from Guinea-Bissau. And our colleague, our WHO colleague in the country office, Claudio Munhenga, who is Health Information Management and Risk Assessment Officer. So thank you very much, both of them, for being here with us today. Doutora Quinta, Dr. Cláudio, muito obrigada pela presença dos senhores hoje aqui.
Okay, thank you, Carolina. So now we'll proceed the presentation. Claudio, please, the floor is yours. In order to keep our participants well aligned with your presentation, I will just kind of ask you for present one slide, then I will try to interpret all the information that you are mentioning to our colleagues. Cláudio, por favor, pode prosseguir com a apresentação. Cláudio, há eco.
Yes, thank you.
I think they are on mute.
Cláudio, poderás pôr o teu microfone on e evitar que faça eco, por favor?
Muito obrigado a todos.
Tá perfeito, pode prosseguir.
Okay, I will go ahead. So Carolina is already present us. So I will present in Portuguese to follow Dr. Quinta, that is coming for the Minister of Health. So, como a Carolina já disse, sou Cláudio Mianga e irei apresentar aqui resumo do apoio que a OMS está a prestar ao Ministério da Saúde no contexto da implementação da telemedicina.
So, as already Carolina present ourselves, I'm here presenting WHO country office, Guinea-Bissau, with Dr. Quinta Isumo, which is the National Director of Health in Guinea-Bissau. And we'll summarize all the technical support.
Pronto, vou aqui continuar. Pode passar para o próximo slide. Next slide, please. A OMS está a usar os guiões de recomendação já elaborados pela HQ, pela AFRO, ou a OMS a nível do país, que é para poder guiar o Ministério da Saúde em todo o processo da preparação documental e todo o processo da estruturação do plano, todo o processo da condução da telemedicina no país, e que neste momento estão aqui na nossa tela os guiões que foram bases de suporte para a elaboração de todos os planos e estratégias para a implementação da telemedicina no país.
The engagement of WHO Bissau team with Minister of Health colleagues was based on advocacy for WHO global guidelines and recommendations, in which have always been well promoted to us by our colleagues in AFRO. So these guides and recommendations have guided us along the digital transformation agenda, in which the health sector has demonstrated the great importance and need to adjust the digital health context. Means that all the plans that we are start to implement in Guinea-Bissau are mainly based on WHO recommendation and guides that are produced to ourselves by our regional office in AFRO. Claudio,
next slide, please. Another slide. De seguida, vou apresentar os passos que já foram seguidos para a implementação da telemedicina no país. Para dizer que, com base no guião da implementação da telemedicina, a OMS a nível do país teve que seguir primeiro a primeira fase, que ficou completamente finalizada, e a segunda fase, o passo 5, também ficou finalizado, e que este é o processo de apoio, de segmento para apoio ao Ministério da Saúde, que a OMS procura seguir com muita rigorosidade, que é para garantir com que haja o alinhamento da implementação da telemedicina com os outros países, neste caso, e seguindo criteriosamente o guião já estabelecido pela OMS a nível mais alto. Obrigado. A tradução, por favor. E, de seguida, após esta tradução, eu vou pedir que a doutora Quinta, como parte do governo, faça a apresentação de todos os processos que já foram elaborados pelo governo para a implementação e estabilização da telemedicina no país.
Thank you very much, Claudio. So, based on the guides that we saw on the previous slides, in parallel to the development and preparation of WHO global implementation guides, at the country office level, they take into very rigorous process all the steps which help them and guide them in order to implement the different phases of the preparation for the telemedicine at the national level in Guinea-Bissau. In this case, it's important to mention also that all these guides, particularly the implementation guides, support them at the minister level, including support as well to technical aspects in the way to proceed for each layers of the guides. Now, in order to also have some very insights from the Minister of Health, Dr. Quinta will take the floor to explain exactly what are the main actions did it after colleagues started to use the guide. It's important to say that before the guide was published, launched, telemedicine was already something in the plans of country office level, according with the request from the Minister of Health. In this case, before the official launch, colleagues already start to use all these phases from phase one. I mean, all these layers from phase one of the implementation guide. Now, next slide, and the floor is for Dr. Quinta from the Minister of Health in Guinea-Bissau. Dr. Quinta, por favor, pode continuar. Salim, next slide, please.
Obrigada, boa tarde a todos. Para continuar, gostaria só de agradecer em primeiro lugar à OMS de Genebra e à sede de Bissau pelo apoio e pelo convite também que nos fez de podermos compartilhar a nossa experiência com os outros países. E na Guiné-Bissau, desde 2020, começamos com esse projeto de telemedicina, graças ao apoio da OMS, o Escritório Nacional. Portanto, começamos com esse projeto devido à situação que a pandemia da Covid-19 nos trouxe, adicionando à vulnerabilidade do país. Então, o país optou-se pelo uso da telemedicina como alternativa. Ok. Tradução, se faz favor.
Yes, first of all, Dr. Quinta, on behalf of the Ministry of Health and all colleagues, we'd like to thank WHO country office in Geneva, of course, all our African colleagues as well, to support them in the implementation of the telemedicine programs at the national level. Particularly during the COVID-19 pandemic, was a real moment that to show how important this tool will help us to strengthen our national health systems. Por favor, doutora Quinta, prossiga.
Obrigada. Logo no início, o Ministério da Saúde, através da Direção-Geral, fez uma nota à OMS, a sede do país, solicitando um apoio na implementação da telemedicina. Foi em novembro de 2020, passamos para 2021. A partir daí, começamos a trabalhar nesse projeto de telemedicina, obedecendo todas as normas da OMS e trabalhamos também sob orientação dos guiões que a OMS criou. E, como o Cláudio acabou de dizer, iniciamos o projeto com a avaliação da situação nacional, onde implementamos todos os 4 passos dessa primeira fase. Faz favor.
As Claudio mentioned, followed the launch of the implementation guides at the national level with the team that we identified to support us in the implementation of the telemedicine programs. We proceed with ever single layers strictly in order to have a good foundations to implement our telemedicine product at the national level. So we start with this, with the assess at the national level, identify the teams, and then we went through the process to see what are the contests and the targets, and of course, and to conduct a very good well analysis in order to proceed with our implementation. Por favor, doutora Quinta.
Obrigada. Então, a partir daí foi criado um grupo de trabalho multidisciplinar que envolve todas as partes interessadas. E a equipa trabalhou, definiu as metas para a implementação da telemedicina na Guiné-Bissau. Foram feitas análises do ambiente, ou então da situação atual do país. Faz favor.
So based on these first steps, what we did, as I mentioned before already, we identified a multidisciplinary team from different services already working some parallel telemedicine programs, and we bring them together in order to assess the environment to start implementation.
Ainda no primeiro slide, após a conclusão da primeira fase, primeiro slide, antes deste, faz favor. Antes deste, voltar para...
Can you get back, please? Yes, thank you.
Ainda não, voltou. O meu não. Ok, obrigada. Então, neste momento estamos na segunda fase, onde já demos o 5º passo e já determinamos mais ou menos o modo como o sistema será desenvolvido na Guiné-Bissau. Próximo slide.
Thank you. So in this case, as already mentioned, so we finalized phase 1 when we assessed all the enabling environment, and now we are in the transitions to the 50 layers from phase 2 in order to start the implementation plan.
Próximo slide. Durante o percurso do nosso plano de trabalho,
Sorry, next slide, please.
próximo, se faz favor, a inglês. Next, please. Então, eu estava a dizer, durante o percurso, o país realizou várias atividades, das quais, na primeira atividade, que era da avaliação situacional, esteve presente a representação da OMS Afro e da OMS Genebra também, conforme se mostra nesta imagem. Próximo.
So in this slide, you can see that during the situation assessment, we have the support from country office, from regional office, from HQ office, from colleagues who support us to really boost the teams in order to really implement the guide, following the process from each layers of the implementation guides phases. Next slide, Salim, please. You can paste this one because this is related to the assessing in an environment that we went through all the engagement about all the countries, excuse me, all the participants at the national level. Next slide, Salim. Yes, thank you.
Após a análise da situação, o país fez um inquérito nacional onde preenchemos, utilizamos o formulário da OMS, que nos apoiou no inquérito da situação da telemedicina na Guiné-Bissau. Depois desta análise, segundo a orientação da OMS nacional, o país teve a oportunidade de visitar o Cabo Verde, porque entendemos que, como o país é um país que nunca implementou a telemedicina, precisávamos de ver a experiência de um país amigo, ou um país que pelo menos tivesse a experiência na implementação. Portanto, foi daí que, com o apoio da OMS, deslocou-se da Guiné-Bissau 2 pessoas do Ministério da Saúde e com o apoio também de uma pessoa da OMS, que é o Dr. Cláudio. A equipa esteve em Cabo Verde no mês de setembro, fizemos algumas visitas nas instalações de telemedicina de Cabo Verde. E o objetivo da visita era constatar em loco o funcionamento de telemedicina lá em Cabo Verde. Também tentar identificar os equipamentos que os cabo-verdianos utilizaram para fazer implementar a telemedicina e aprender também com a experiência deles.
So, follow the assessment situation from at the country level was very recommended by WHO country office to identify a country experience in telemedicine implementation, in this case Cabo Verde, where a delegation from Guinea-Bissau went to Cabo Verde and vice versa. And then colleagues from Cabo Verde came to Guinea-Bissau also to assess the context at the national level and to identify what are the to change knowledge and to see how the implementation could be well done in the certification process. Why Cabo Verde? Cabo Verde is also a Lusophone country, not so far away from Guinea-Bissau, it's less than 2 hours flights. And they are exchanging experience in the implementation process. Why Cabo Verde? Cabo Verde is a country which has very strong implementation in telemedicine. They have a very good strength. They have a very good health system in data for telemedicine. The reason why they have this exchange experience between countries, Lusophone, Guinea-Bissau and Cabo Verde. Next slide, Salim. Thank you. Next, Salim.
Como o Bento acabou de dizer, após a nossa visita em Cabo Verde, também o país entendeu que valia a pena a equipa de Cabo Verde viessem cá para poderem ver a situação real do país, para assim poderem nos apoiar na implementação da telemedicina. E foi assim que, depois das 2 visitas realizadas, a Guiné-Bissau em Cabo Verde na Guiné, iniciou-se logo a elaboração do plano de implementação, onde o país, até o momento, já conseguimos fazer a avaliação atual, já fizemos uma sensibilização aos médicos e a todas as partes interessadas que futuramente poderão trabalhar ligado à telemedicina. Já foi nomeado um coordenador nacional e também estamos na fase de nomeação dos coordenadores regionais. Já temos a listagem de equipamentos de acordo com a orientação de Cabo Verde e também já identificamos o centro de telemedicina de Guiné-Bissau, que funcionava anos atrás, depois parou. Identificamos as necessidades que existem lá de fazer algumas reabilitação e melhoria para poder ser utilizado.
Okay. So follow this visit from technicians from from Cabo Verde to Guinea-Bissau and vice versa. So the team at the national level, they start to sensibilize at the national level to identify the teams. They identify a national coordinator to support the program, and also telemedicine center where will be, the nuclear area where they're going to start to implement the telemedicine program. And so far, they also identify what are the main needs, particularly at the health infrastructures to start the implementation of the telemedicine. Next slide, Salim, please.
Ok, obrigada. Então, esta mapa é mapa de Guiné-Bissau, mais ou menos tentamos identificar os locais, ou então as estruturas sanitárias que futuramente poderão levar os equipamentos da telemedicina. Portanto, são no total 17 centros que a equipa escolheu para colocar os equipamentos de telemedicina. Esses centros estão localizados em todas as regiões sanitárias do país. O objetivo é fazer com que os técnicos que trabalham nas áreas mais distantes da capital, que tenham a possibilidade de poderem compartilhar as suas dúvidas com os que estão na capital e também os da capital com os que estão nas zonas rurais e vice-versa. Também, por outro lado, queremos com esse mesmo aparelho que será montado a nível do centro, que houvesse uma interligação com alguns hospitais fora do país, por exemplo, Portugal e possivelmente com Cabo Verde também, que haja uma conexão com hospitais fora do país para nos facilitar na discussão, então, para apoiar no diagnóstico e formação local dos nossos técnicos.
In this case, so we can see on this slide you can see the Guinea-Bissau map where colleagues at the national level they identified technical areas through the connectivity for connections to the telemedicine services. It means each area is a health center. The interest is they identify 70 centers through the telemedicine program. They also have the ambition to see how they can share some knowledge between other hospitals, in this case, Cabo Verde or even Portugal. In this, just to make it very clear, the first modality will be providers to providers. So this is where they are so far. Of course, this is all based on the implementation guide, which support them to really streamline each phase in each actions according to the guidelines providing to WHO. Next slide, Salim, I think is the last one. So just to say thank you very much, and just to reflect one point, the implementation guide is also already translated into Portuguese. That's
Ok.
why they have this facility to implement it. Dr. Quinta, over to you.
Sim. Estes foram os passos que a Guiné-Bissau deu até aqui e ainda estamos a trabalhar. Esperamos que em breve o país vai poder experimentar o uso da telemedicina na nova modalidade, conforme a orientação dos guiões da OMS, para facilitar com que os nossos concidadãos que vivem mais longe da capital tenham acesso à saúde. Tanto esperamos contar com o vosso apoio, que desde sempre que vocês têm nos apoiado, espero que vamos conseguir atingir o objetivo. Obrigada.
Okay, so Dr. Quinta just say thank you so much for all this support, and they are very anxious to start this implementation and could continue the support from WHO implementation guys, and also to see how we can keep support the team at the national level. It will help to approach these health services along the country, particularly remote areas. Thank you very much, Dr. Quinta, and thank you all participants for understanding this process of translation. So we try to do our best, and this is what I have to share with all of you. Thank you, Claudio, and thank you, Dr. Quinta, once again. Celine, the floor is yours. Over to you.
Thank you so much. Thank you so much to the team, Dr. Quinta, Claudio, Pascual. Like we are like kind of like overtime a little bit, not overtime, but not on schedule. But so I'm gonna ask. Here we added the Kaloyan, and there was a mention a lot too about like another guide that was like released earlier last year, and I will ask Dr. Camilo Kaloyan from the Sensory Function and Disability and Rehabilitation he's a technical officer to kind of like give a brief overview of like another guideline that is like coming with the one that like Tikas just mentioned. I think they kind of like complement each other. Kaloyan, if you can take the floor and then give a quick overview, and I would like to spend some time for the Q&A, even if we have 5 minutes afterwards or something like that.
Sure. Thank you, Salim, and hello, everyone. I'm conscious that we have just 5 minutes, so I'll be very quick. I just wanted to present another technical product that WHO, together with the International Telecommunication Union, developed and launched last year. This is a global standard for accessibility of telehealth services. So its main purpose is to ensure that when countries adopt or implement any telehealth solutions, these are accessible and they can reach persons with disabilities, and not just them, also any marginalized populations who might have challenges with the access and use of telehealth services. So this is a separate technical product, which means that countries can adopt it if they want to ensure this accessibility for their telehealth services. But to a certain extent, it can also be seen as a complementary or integral to the implementation guide that we have been discussing today. So if a country wants to implement the guide, then one of the steps can be also to integrate this standard for accessibility. As Dr. Sood mentioned, India is actually the first country that has expressed interest in adopting, and we are currently in conversations with them. I will put in the chat the link to the standard. So if you have any questions, I will also leave my email, so you can always ask me or Salim or Pascual or anyone from the WHO colleagues. So I'll leave it here, and back to you, Salim.
Perfect. Thank you, Kaloyan. And please use the link that he will be sharing, and the guidance is like something very like thoughtful and like really useful. And just to mention here, we've seen two examples here. There's one that is like already scaled up, which is like Sanjay's example, and then in the case of Guinea-Bissau, which is like starting from scratch, the guidance that we provide can actually be as well brought up even in a scale up later. For example, in the case of Kaloyan, like guidance, they are already like engaged to implement that, make sure that the guidance is implemented, even if like the product is scaled up a lot. So yeah, just quickly we go to Q&A. We have 3 minutes. There were some questions on the question and answer, Zoom question and answer. What I would suggest, I've seen that like some of them were answered already by the presenters. Maybe what I would suggest is like that people take over, and then I would like that it will be kind of like a live session where you can just put your hands up and we allow you to talk if you have any questions. And we have like maybe 3 or 4 minutes, so it would be great that like people engage a little bit.
So then if I can just add some point to colleagues and the audience, just to let you know, all of you, that the implementation guides and the disability standard that was provided by our colleague Kaloyan and Tiges, they are both translated to French, Portuguese, and English. So our idea is to approach max as we can from the regional WHO perspective colleagues to use the guides in these three languages, and we are planning to also translate to other language as soon as possible.
Perfect. Thea, you have the floor. I've seen your hands up.
Yeah, I have a question for Tigist. Hi, Tigist. I have a question about the data quality of the data that you received by of the guidelines that you have recommended, that the WHO has recommended for telemedicine. So you will get data, I guess, and then you might want to use this data for secondary purposes. Do we have any measures to ensure any recommended measures to ensure the data quality, or any recommended frameworks to ensure the quality of the data? That's one question. My second question is to the eSanjeevani presenter. Sorry, I didn't get your name too well. I have a question about the gender disparity. So typically, studies have shown that women have better health-seeking behaviors, but in your work, you've shown that the people who sought these telemedicine services, 1% were women, while 42% were men, and I think 57% were diverse. So I would like to understand what is the cause for this disparity. Yeah.
Perfect. Maybe then we start with Tigist first.
Thank you. So maybe just, I'm not sure, so data can mean a lot of different things in this context. So when you mean quality of data, there is the data that contributes to the statistical reporting, the HMIS. So whether the data that is done through a virtual consultation actually is as good of a quality as data that would have been collected if a person came in for a physical service, I think from that perspective, I don't think we have enough evidence to see what the difference is, though one of the big issues in telemedicine that we've seen is that it relies on a lot of self-reporting on behalf of the patients. So a lot of health workers have noted to say that they can't diagnose the way that they would traditionally have diagnosed something, just because they don't have the full capacity to be able to check things or, have the physical contact for that. So in terms of how data is reported, there could be some differences just due to the fact that a lot of this is done through virtual and that physical contact is done. But there are a lot of guidance tools as well within the training packages to try to make sure that there's appropriate probing, that there's, the clinical case management protocols are updated to make sure that they can account for these issues. So maybe I'll just address it through that, and when Dr. Sanjay, when I hand it off to Dr. Sanjay, maybe he can also look to this question in addition to the other ones with his direct Sanjeevani experience in terms of the data management.
To start with, I'm really sorry for the mix-up there. There's an error in the depiction. The icon has been interchanged with in the presentation. 57% have been women and 1% have been diverse. So that stands to be corrected. And as far as your previous question is concerned, we've seen that normally the quality of data is not so good when we roll out telemedicine services, because the users are not well aware of the potential that the data holds for public health as well as for other interventions. So to overcome the issue of, or rather to ensure that we get clean data and good data and the system generates rich data, we have put in place the mechanism which I talked about, is the case completion score. So the entire EHR has been the template of the EHR has been programmed at the back end, that for every entry that the community health officer would make while creating the electronic health record would fetch a specific score to the entire EHR, and each EHR would have to be submitted only after it has attained a specific score. So this is one of the options which the guide also talks about it very lightly, though, that clean data can be ensured by putting in place such measures. And this is one measure that we have incorporated in eSanjeevani. wherein the system would take care of the fact to some extent that the data is clean and the system is rich with data when the case is sent to the doctor on the other end. So there could be many such modalities which could be put in place in the system to ensure that the patient then sends more and clean data to the doctors.
Perfect. I'm just like we are like over time. Carolina, would we be able to extend for 2-3 minutes, or you want to? We can take over like the questions later, or through email or.
As you wish. I'll be happy to extend 2 or 3 minutes, but we can also write them down and then share the answers later on as you panelists prefer.
Okay, I think we can extend and maybe give the floor to Tony Shibani. You have the floor.
Thank you, sir. I hope I'm audible.
Yes, you are.
Thank you. No, thanks for the two guys that were presented to us just a while back. And I'm happy that Guinea-Bissau is already a step ahead in terms of implementing the first guide. But interestingly, I think for Botswana also, we want to pursue the telemedicine program. And one would need to get proper guidance. In terms of the two guides, I didn't see any, sharing of information around policy. How do you address telemedicine policy? Because I believe that it will be very dangerous to move ahead and start implementing telemedicine projects in the absence of a telemedicine policy. That especially if we want to present telemedicine as a service to the nation. So, are there any areas that really are going to be considered in those two guides? To be able to just give proper guidance on how to address policy issues around telemedicine. Thank you.
Maybe I give like first the floor to Kaloyan, if you can, if you're still here.
Sure, yeah, I'm here. I'm happy to answer. So probably Tigist will be in a better position to speak about policy because the guide on accessibility is just a technical guidance. So this is things that telehealth platforms need to ensure and include things like, having captioning or being able for blind people to read through screen readers. So these are all technical features of the platform, and it doesn't cover issues on policies. But I guess, Tigist, in your case, you can speak more about it.
Yes, so this is a very big issue. So one of the things that the guide does try to do is actually provide bullets of what should be included in those regulatory documents. And I think there's a broader effort within WHO as well to start compiling regulatory documents across different countries so that could be used as reference. Within the guide itself, we actually provide links to countries across the different WHO regions of their regulatory documents so that could be used as a framework or as a reference for those that are looking into it. And one of the big bottlenecks actually to telemedicine implementations is not having this broader regulatory framework in place. One thing that we're hoping to also expand on with, from the lessons in doing this work is the financial and purchasing arrangements that need to be done. And this is something that we're hoping to take forward in terms of understanding what does that purchasing arrangement, the financing, the payments, the reimbursement schedules, what do those look like? So these are things that we're hoping to expand on even more as we learn more. But just to say that there are some pointers and some country examples that we wanted to point to include within the guide as reference. And that also addresses the question for the consent as well as the legal aspects. I saw two questions around there and hoping to address that with this answer. Thank you.
Just want to add to get, so we all are part of like a working group called the Working Group for Telehealth Working Group. And the part of like regulation, as mentioned, like there's a lot of discussions into bringing, guidance on those aspects. For example, at the cross-border, like there's a lot of, talk about cross-border execution of telehealth. How do you regulate that and others? So there's a lot of guidance that are going to be kind of like, augment what we have already. That's going to come in the future. So yeah, just to mention that. And please, I just put my name there, so you please, if you think that you can join the working group, would be great, and give input. Thea, you have your hands up again, but there was Ali Habib that was already, I think, with the unmuted, so maybe we can start with him and then we come back to you, Thea. and then we will stop there. Ali?
Hi, sorry, that may have been an accidental unmute. My apologies.
Okay, so you don't have any questions. Okay, Thea? Thea, you have your hands up again?
Yes, I'm sorry, I was muted, I didn't know. So typically, one thing that telemedicine and basically any digital health project, a challenge that is commonly faced by this, is that the healthcare workers are hesitant to adopt this kind of projects or this kind of practices, especially because they tend to interrupt the workflows that already exist and that have existed and worked well for so many years. But if we have 94 million people using this platform, it means that this is great success. And I'm interested to know, what is it that incentivized or motivated these healthcare workers to adopt it so much that we have 94 million people using this platform, especially in a remote area in a developing country?
You're talking about the eSanjeevani, correct?
Yes.
Yeah,
Go ahead.
That's a good question. In fact, the government of India has, to some extent, incentivized as well the use of the telemedicine platform on the doctor's end. And the community health officers there have also been trained, and they are happy about adopting this newer modality, which enables them to feel more learned and more, growing with the trend. So that is what. Besides this, I think it is the health administrators who have ensured that the platform, which has shaped into the crown jewels of digital India, is utilized, and as a result of which the access to health services is increasing. So it is the policymakers plus the political will, of course, and also the inherent liking towards the technology-oriented interventions in delivery of health services, which has boosted the adoption of telemedicine or motivated the health workers to provide this platform for the patients or use it for the patients.
Thank you.
I think we will stop here. I don't want to extend too much after people are going to start to go. Wanted to thank everybody, and then just mention one thing, that the work is still ongoing. This is not the end. This is just the beginning. There is lots of guidance to happen. There is lots of collaboration to happen. There is lots of knowledge sharing. A community of practices are going to be set in place to execute. And I give the floor to Carolina now to kind of put the closing remarks there. Thank you, Carolina. Go ahead.
Thank you so much, Salim, for facilitating the session. Thank you, speakers, Tigues, Dr. Sanjay, Claudio, Dr. Quinta, Pascual, everyone who was with us today. Just on a quick note, webinars fulfill the knowledge brokering role of this health data collaborative. So we encourage everyone who would like to present on a topic of interest related to health data to reach out to us via the HDC Secretariat at who.int, the email who sent you the invite, as we still have some spots available for this year. And our next HDC webinar is scheduled for the 21st of February on the theme Improving Monitoring Capacity in Humanitarian and Fragile Settings. And the HDC Secretariat will send out an invite very soon, along with the recording of today and the slides or any additional materials that the presenters would like to share. Once again, thank you very much for having joined us today, and see you at the next webinar. Thank you.
Thank you very much. Bye.